Hey everyone, I'm Phil. I'm a master's student in biochemistry.
And I am Matheus, a master's student in biomedical engineering.
You are listening to Orders of Magnitude, the science podcast in which we talk about various scientific topics at all scales, from the shortest patient recovery to the vastness of the subjective experience of the patient.
Absolutely. Today we have with us Dr. Julio Flavio Fiore. He is an assistant professor at McGill University and the co-director of the Department of Surgery. He did his Ph.D. at the University of Melbourne in Australia and his postdoc at McGill as well.
Dr. Fiore is an expert in looking at how patients perceive their treatment after the operation and how we can tweak a few things here and there in order to make the life of the patient better.
We were talking about several topics, including patient-centered care, what is that? And we even went into the opioid crisis. And what does post-op recovery have to do with that?
Yeah, what I really liked about Dr. Fiore's approach is that on one hand, he was looking at the subjective vision of patients, but also he was looking at so many studies, a lot of data. Mm-hmm. And this is so complementary. I hope you will like it.
Have a good time. Dr. Julio, welcome to the podcast.
Thank you so much. Thanks for having me.
Thank you very much for coming. So today we're talking about many different topics, going to patient care. We'll even go into the opioid crisis, and post-surgery research is mostly what we do. But before we get into the science, we would like to go a little bit into the person, who you are. Why don't you tell us a little bit about yourself and how you got where you are right now?
Sure, absolutely. So I'm originally from Brazil. I was born and raised there. And I did my undergrad in Brazil. I'm a physiotherapist by training, but I had very little experience in clinical practice, maybe like 5 or 6 years, because since my undergrad, like in my second year, I really fell in love with research, and I started getting involved with like research projects in my university there, which was like in a small town called Piracicaba, which is in the countryside of São Paulo. And I think like it was pretty much since my first or second year that I set my mind into research and really like got in the mindset of like having a research career.
Yeah. In physiotherapy, what is the research like? Is it research on sport? Is it research on recovery from injuries? What kind of research is it?
Like, of course, there is a lot of research focus like on sports. There's also like a lot of research focus on neurological rehabilitation, which is like a very strong, like, we have some very strong research teams here at McGill focused on that in the physio department. But there's also a lot of research focused on hospitalized patients who like rehabilitation of patients after an ICU stay, and also rehabilitation recovery after surgery, which is the field that I ended up being like specialized in.
Were you doing this type of research on post-surgery starting from your master's right away, or was it later in your career?
It was starting from my master's. My master's was in respiratory sciences in like resp department in one big university in São Paulo. But my master was focused on post-operative pulmonary complications, patients undergoing cardiac surgery. So it was kind of like half and half focus on like respiratory sciences and surgery. But it was then during my master's that I really fell in love with like working with surgical patients. And then after that, I moved to Australia for a PhD. And my PhD thesis was focused on colorectal surgery, on developing like new ways of measuring recovery of patients during hospital stay by measuring kind of an alternative measure to assessing hospital length of stay, assessing like in hospital functional recovery. And then after that, I came to Canada for a postdoc, and I've been here since then.
Amazing. That's going quite different places in the world. Yeah. Australia sounds like a really nice place, especially if you're living from Brazil. It gives a little bit, because then you don't have to go through the cultural shock at the same time as you go through the winter. That's
exactly.
That's a hard part when you come to Canada, is going through the winter.
Exactly. So the weather in Australia is really amazing, and yeah, it's a very nice place to live. Like sometimes I miss there a lot. The only problem is that it's far. It's literally far from like everywhere.
Right.
Everywhere.
Right.
But Australia definitely did not help with my accent, because like I already have had like a very thick Brazilian accent. I moved to Australia, it got even worse. So like I apologize if some things I say like are not very clear, but you guys can ask me to repeat like as many times as you want.
We are three people with accents here: French accent, Portuguese accent, a
Whatever
bit maybe.
accent.
Yeah. And so we all have
That
accents.
often happens with people that immigrate to English countries. They get the little accent from that country, but mixed with the accent from their country of origin, and then they get, I don't know what accent, just a mixture, right?
Exactly, yeah.
Just a couple of sounds here and there.
Yeah.
No, but you're very clear. It's very easy to understand you.
Perfect.
No worries there. All right, so let's go into the research. We wanted to talk a little bit about patient-centered care. Can you develop on that idea? What exactly is patient-centered care?
Sure. So patient-centered care is care that is focused on the views and the needs of patients, which is something that like people really didn't think about a lot until the 90s, and this concept really started blooming after that, which is like pretty much like caring for patients based on what they need and their views of like what they consider to be like a healthy like state. And also doing research that is focused on outcomes that matter to patients and not only to clinicians or other healthcare providers.
How was the care compare? How do the two different types of care compare? Let's say there are two different types of care. The care before the 90s, before this idea of patient-centered care came up, and care now. What were the differences? How did clinicians work?
So I can give you clearer examples in terms of research, like researching surgery, for example, which is my field.
Yes.
Most of the research done in surgery until recently was focused on outcomes related to post-operative complications. So like with like very specific diagnosis of like anastomotic leaks, risk of like post-operative pneumonia, risk of like reoperation and etc. And focus on hospital length of stay. So there were like huge revolutions in surgical care that were done based on these type of outcome measures. For example, there is a concept nowadays that started in the 90s, which is called enhanced recovery, which is a bundle of interventions that are like offered to patients like during their hospital stay that is meant to accelerate recovery. And this intervention, like the effectiveness was pretty much like the assessment of effectiveness was pretty much based on like reducing hospital stay and reducing complication rates. But to patients, these are like what our research is showing on and on is that these are not the outcomes that patients are most worried about. Like patients are a lot more concerned on them, like after hospital stay, going back to their regular activities, being able to go back to work, going back to their regular like sports activities, like if it's a younger patient, for older patients, like taking care of their grandchildren and etc. And this is really the outcomes that like current research is trying to focus on. But we'll talk about this later, I'm sure, but it's not that easy to focus on these outcomes.
So the patient is no longer passive in this process. We focus, and the measurable outcomes that we focus on are the ones that are important to the patient rather than being important to the medical field by themselves.
Exactly.
We want the patient, after especially such a traumatic procedure as being opened up, right? Undergoing surgery is very traumatic, and going back to your normal life is important. And what is a normal life in the eyes of a patient? Well, we have to ask them in order to know, right?
This that's actually a question that Phil and I were discussing earlier that I had. Is I understand how or why scientists and clinicians are interested in things that can easily be measured, like length of stay in the hospital, or the rate of infection after a surgery, or these types of things that the patients don't think much, because they're easily measurable and we can control them and we know how to change them, right? But if we start focusing on things that the patients care for, these things are much more subjective. So a question that I had was, how can we use that information to truly care for the health of people? You understand the question?
Yes. As you mentioned, like measuring outcomes from the perspective of patients is not that easy. And like traditionally these measures are taken like using questionnaires where patients like fill out questionnaires about their health status like after surgery and tell like the researcher or the healthcare team how they are in terms of having like adverse events from like perioperative care interventions, such as, for example, like nausea and vomiting after anesthesia, how they are in terms of their bowel function, which is something that is highly affected, especially after abdominal surgery, because it can take a long time for the patient's like bowel function to return to normal. How patients are in terms of their like physical function. Are they able to get out of bed and do like basic activities in the first week after surgery? How do they progress into like more demanding activities, and etc. But developing these questionnaires are not super easy. It's not just a matter of like a group of clinicians getting together and coming up with a bunch of questions that they think might be relevant to patients. So this is a big focus of my research program. Like we did a series of systematic reviews of the literature and identified that the questionnaires that are currently used to measure recovery, they don't necessarily have very good measurement properties, and they were not developed according to current standards for developing this kind of questionnaires. So we decided to start like a program from scratch to develop a new questionnaire to assess recovery, and we're specifically focusing on abdominal surgery patients.
And that's the study in which you go and instead of asking questions to the patients that are pre-made, you go and talk to them in one-to-one interviews, what we call a qualitative study.
Yeah.
I had never seen a clinical qualitative studies. I had seen psychological qualitative research, but never in clinic. So how did it work, and what did you learn from this study?
It's something that we've been using a lot, like qualitative approaches in clinical research, let's put it this way. And it's something that it's like relatively new to me. It was pretty much like only after coming to McGill that I started like getting more involved in qualitative research. But the development process of like any questionnaire that are used to measure patient outcomes, it needs to start from qualitative work.
Because you need to develop those constructs, right? Those ideas of what are we going to measure.
Yeah, exactly. So, and the good things are like there are very specific frameworks or like guidelines on how to develop these questionnaires in a proper way. There is a very like comprehensive guideline by the FDA. There is also like SPOR, which is another like association from like, it's actually an international association that is really focused on patient-reported outcome measurement. And the recommendation is that like we should really start from qualitative work to understand how patients conceptualize your outcome or your construct of interest. So in our case, we went around the world, like literally interviewing patients. So we did interviews with patients undergoing abdominal surgery in 5 different countries. Like here in Canada, we interviewed patients, both like English-speaking patients and French-speaking patients. We interviewed patients in Brazil, in Japan, and in Italy, and like asking them, like patients, like what were the main like issues that they experienced after surgery, how they when they did consider or would consider themselves like fully recovered from surgery. And based on that, we developed what is called a conceptual framework, like with what would be the structure of the future questionnaire, like specifying exactly what are the concepts of health or the health domains that should be covered by a questionnaire measuring recovery. And then also based on the interviews, we developed the questions, the specific items for the questionnaire. And now in the next phases, we'll like administer these items to patients and then use specific statistical techniques to identify the best items. So we are able to score and have like a final numerical score of recovery that we can use like in research on the comparative effectiveness of like different interventions that aim to improve recovery for patients.
That's a great example of how qualitative and quantitative research, they work hand in hand rather than being two sides of a coin that we can't that we can't have both sides, right?
Exactly. Absolutely.
And it's nice to do on one side, because if I remember correctly, the qualitative study, you did it with 17 patients. Because in order to ask those open-ended questions, how did your surgery go? How did you feel after? You can't do that at a very, very large scale.
Yeah.
And then once you develop those constructs, those measurable outcomes according to your guidelines, then you can develop these new questions that are the new standard. And now you're saying the research you're currently doing is on applying those new questions in order to have better measures, quantitative measures now of many, many patients.
Exactly.
Mm-hmm. Okay, it's still unclear for me, I find, how these measures can become quantitative if they come from subjective answers from the patients. You see what I mean? If you ask a patient what he thinks is a good recovery, and one patient will say, if I can walk and play with my grandchildren, then I think it's good enough. But then it's another patient that will want you to go back to 100% and has a completely different idea. Oh no, I consider myself recovered if I can just sit on my bedroom, on my living room. You know, how can you take such different answers and take out numbers from it?
Like, for the type of questionnaire that we are developing, like we're developing a questionnaire that covers like different domains that are relevant to patients.
Mm-hmm.
And so we'll have like what the questionnaire will like cover domains, for example, related to like physical function,
mm-hmm.
other domains that are related to like function of like organs, such as like patient's ability to eat, patient's ability to like have a bowel movement, and etc. And other questions are focused on like fatigue, on like more like subjective elements of recovery, let's put it this way. Another domain like focused on pain.
Yeah.
And the statistical technique that we use to make this like numerical score that makes sense, it's a process called like rash analysis.
Mm-hmm.
And it really helps us like identify what are the best items, the most like informative items. So we're able to have a continuous score that can be used as a continuous measure in research.
Mm-hmm. I see.
So it's not that we're having like one overall question that like we'll ask patients like, how are you recovering from surgery? So we are like focusing on the whole construct, on the whole like framework of recovery as we like identify in the previous interview. And based on this framework, we'll like statistically we'll get like this information and like to statistically come up with a unique score.
So would you have, with the new questionnaire then that you develop, would it maybe look something like, a question would be, how would you rate your ability to do X activity? From 1 to 5, and the patient rates from 1 to 5, that gives you a score for that question, and then you have a sum of those scores for that specific category of questions.
Yeah.
That's more or less how the work
Exactly.
Oh, I see.
Yeah.
And once we know this information, how can we now change the way that post-op care is done to improve, just recovery of the patients?
So there are like some like important applications of this type of questionnaire and this type of information, both in research and in clinical practice.
Mm-hmm.
Like in research, as you can imagine, like if we're doing like randomized controlled trials comparing different surgical techniques that are meant to improve recovery for patients, for example, like using a less invasive procedure compared to a more like invasive procedure, or even using different interventions that aim to improve recovery, such as, for example, nowadays there's a lot of like focus in the literature on prehabilitation, on like preparing patients, like getting patients fitter for surgery through like exercises and better nutrition and etc. So this questionnaire will be used on research focus on the comparative effectiveness of this intervention compared to, like, for example, standard care, and be able to give us a numerical value of like this was like the mean recovery score for this treatment arm.
Yeah. So all these practices, for example, changing the nutrition of the patient, it's nothing magical. It's not that new hot drug on the market that's going to make thousands of dollars or millions of dollars to pharmaceutical, but it makes a difference in the life of patients, and we just have to find these small tweaks to do in the post-operative process.
Like, it may make a difference, but it may not. The thing is that, like, a lot of these interventions are very resource intensive, such as, for example, like prehabilitation is something that requires like patients coming to the hospital a few times a week, like in a period before surgery. It involves like a lot of equipment, such as like treadmill for the patients, like to patients exercising, and human resources in terms of like staff time. So it's something that costs money, and we really need to be sure that these interventions are making a difference on like patient outcomes. And it's through these type of measures that like doing high quality research will be able to like identify whether the government should be spending money on preparing patients for surgery and using the patient wait time for surgery to prepare them, or if they should use this money to perhaps hiring another surgery and reducing like waiting time. So
yeah, it's true. There's like this calculus also on top of whether it works or not is, are the resources worth it? Should we just decrease the waiting time? Because the waiting time also in the pre-operative care must be one of the parameters that change measurable outcomes. Yeah,
that's what's in health economics. It's called opportunity cost.
Yes.
So like for every dollar that you spend on something, like you're not spending that dollar on something else. So comparative effectiveness research and clinical research really help us like find this balance.
So that's amazing then, because then your research is not only being very beneficial for the patients only, but it's beneficial for, let's say, the system in itself. Right, because then the patients will have better recovery at the end from the surgeries, but at the same time, the hospitals and the government might be saving money at the end of the day. Yep. So it's really it's a very big picture type of very big scope, I think, of outcomes. Yeah. Okay. Now there was this other one paper that you sent to us talking about the opioid crisis in how the post-operative care might be involved in the opioid crisis that we have in North America today. Can we start by just talking a little bit about the opioid crisis itself? What is it? Can you give a general description?
Sure. So, the opioid crisis, if you live in Canada or the United States, if you haven't been living under a rock in the last 10 years, you heard about it. So, it's a crisis that started, in the mid-90s, and something that, it's a crisis that, killed thousands of people both in Canada and the US. And opioids are drugs that are used for pain relief pretty much since ever the history of opioids and opioid prescribing for pain management, something that goes back 8,000 years at least perhaps. But this crisis became very evident in the mid-90s because, first of all, several patient associations and associations focus on quality of care started identifying that pain was not being adequately measured, not adequately managed. Both for patients staying in hospital and also for patients in outpatient settings, such as patients with chronic pain. And started really calling for actions to improve pain management. And the pharmaceutical industry saw that as a great opportunity to develop new drugs to, of course, with the best intentions to benefit patients, but also make a lot of money out of it. So At the time, the evidence about like adverse events of opioids, it was clear, but they kind of twisted things in a way and like put a lot of focus on studies or even pseudoscience like studies saying that it wasn't a big issue.
Yeah.
And it started like marketing several drugs that are like combinations of opioids with non-opioid drugs and opioid drugs that have like extended release that the patients can take like 2 pills like per day, like every 12 hours, and these pills like stay like acting longer and relieving like pain throughout the day. Exactly. So like things started going downhill pretty much from there.
Yeah, a stat that struck me in the paper you sent us is that up to 10% of the people who are prescribed these drugs, what is it? Is it they become addicted or they take them for longer than they should?
They, like the metrics that we have in surgery, like now we're talking about like surgical patients, like specifically, like surgery is often like a first time opportunity for patients to have like contact with opioid drugs.
The gateway,
Because exactly, like especially here in North America, over 95% of the patients who undergo a surgery, even like minor surgeries, they receive an opioid prescription, which is not the reality in other countries. And the research estimates that like up to like 6 to 10% of these patients become persistent opioid users. The metrics that we have don't indicate necessarily whether they're becoming like addicted to opioids or if they are like just misusing these drugs for longer, or if there's like any issues with the surgery or the perioperative care itself that made them like develop like chronic pain. But the fact is that like up to 10% of patients, they continue using opioid drugs beyond 3 months after surgery.
Yeah. And there was also a high percentage from that study as well. It was mentioned a high percentage of opioids that are prescribed is not often the whole prescription that is used.
Yeah.
And then there's another problem going into the opioid crisis, because if you're not introducing someone new to an opioid addiction, then you're kind of pushing more drugs outside of the hospital that can be used for other things.
Exactly. And there are like some very interesting statistics showing that like up to like 60% of people who misuse opioid drugs, they are like their main source of opioids is like taken from family members or friends. So this is another like very important like phase of the problem with like surgical patients. Like these patients are like overprescribed opioids. They don't need as many pills as they are prescribed, and these pills just like end up like sitting in their like medicine cabinets and like become available to someone else.
And it was quite a good study. I found a good review. What was it? 51,000 papers that were looked over, 4,000 papers that you actually read to come up with everything. The goal was because although in North America we're using a lot of opioids for treatment, post-operative treatment, there's not a lot of research supporting that, or the research is not well organized. So I wanted to put everything in a more organized fashion in a single paper, right?
Exactly. Yeah. The paper that you're mentioning was a scoping review, which is like a type of like review of the literature where you're pretty much like mapping what's the research out there. You're not necessarily like looking for study results or looking for results that may change clinical practice. You just want to like map what's out there in terms of research, like to identify the specific gaps where like research groups may act on to like find new evidence and generate new knowledge in a specific field. So, and like this was like literally the first step that we took in our research program, which like expanded quite a lot since that paper.
And one of the main themes of the paper that I understood was exploring options other than opioids for pain treatment after surgery. Can we talk a little bit about these different options? What would be other options than opioids?
Sure. Like, what's one of the things that kind of like drove me to like this research field is the fact that like being from a different country, being from outside like North America, and also like living in other places that have like a different healthcare system compared to the US and Canada, is that like opioid drugs are rarely prescribed to surgical patients after post-operative discharge in other places. Like it's like opioid overprescribing is starting to become like an issue in some places in Europe, but like largely like worldwide, like patients are pretty much prescribed only over-the-counter drugs to control their pain, such as like acetaminophen and non-steroids, anti-inflammatory drugs, which we call NSAIDs, which is our like ibuprofen, naproxen, like like drugs that people take on a daily basis for pain, for headaches, and etc. And the things are like we don't have much evidence that opioids are superior to these drugs. And this is something that like really my group is focusing on now, like doing research, like doing randomized control trials, randomizing patients to receiving opioids versus receiving only non-opioid drugs, and comparing their outcomes in terms of pain, in terms of how like pain affect their daily function, and etc.
So then, if I understood well, you have a pool of patients, and the patient doesn't know if he's getting opioids or not. And you will give them a questionnaire, I imagine, asking about pain and pain management to see if there's any differences between patients that received opioids and patients that did not.
Exactly.
Okay.
Exactly. The type of research that we do here, we don't like leave patients blinded. We do what we call like pragmatic trials, which are trials that are like embedded in clinical practice without much blinding of patients or clinicians. Like our outcome assessors are blinded, but the clinicians and patients aren't.
I see. Sorry, I'm not sure to understand. What is the difference? What is an outcome assessor?
Outcome assessor is the person who will, for example, be interviewing patients during the evaluation of their pain.
And if you do such a study and the patient knows that he didn't get opioids, which is usually what is prescribed in Canada, won't they have a bias to maybe say that, I felt more pain? I think it was because they think, if I had the opioid, it wouldn't hurt as much.
Yeah, this is a potential source of bias. Yeah. But like what's very interesting, like we just finished a large pilot randomized control trial on this field with patients undergoing outpatient general surgery, so like breast surgery and abdominal surgeries. Yeah. And some patients report, so we interviewed like these patients before surgery. Some patients are really afraid of not taking opioids because they don't think that like giving only non-opioid drugs will be enough to control their pain. But several patients are like in the other end of the spectrum. They don't want to take opioids whatsoever. They're very scared of the side effects of opioids, scared of like becoming addicted. Some had like very bad experiences with like taking opioids in the past because of other surgeries or other like sources of pain. But long story short, like this can be a source of bias that needs to be like very well reported in like your study. When you're like in your paper, in your discussion session, like that's definitely something that needs to come up in these like type of like pragmatic trials.
Yeah. So then the options that we have now we have opioids, which is often used in North America. In other countries like Europe, or if you go to Asia, they use these other drugs. What was the term again? Non-inflammatory.
Over the counter.
Yeah, over the counter, like painkillers. So
yes,
like
over the counter.
Ibuprofen, Tylenol. Yeah.
Right. So other drugs, other pharmaceuticals, and there was this very small section in the paper talking about non-pharmaceutical approaches.
Yeah.
What would those be?
Those would be like there are what we call like physical non-pharmaceutical approaches, which is like icing the wound. I see. It's a very popular one and something that it's like has been more and more studied in the literature. And the others, on the other hand, we also have like psychological approaches, which is like relaxation, cognitive behavior therapy, like before and after surgery, to like get patients in the mindset where like accept that they will have a certain level of pain and learn to like live with that and live with it and like deal with that for like the first few days or week after surgery. So these are the approaches, like overall the non-pharmacological, what we call non-pharmacological approaches.
And these work, going to a therapist and doing CBT for a little while and learning to accept the pain does it decrease the perception of pain?
There is research in chronic pain showing that, yes, it benefits patients, but chronic pain is a completely different ball game compared to acute pain after surgery. Unfortunately, after surgery, we don't have much evidence that these non-pharmacological pain interventions work. And this is something that we're working on right now. We're doing a big literature review, like a big meta-analysis comparing like the use of non-pharmacological interventions to standard care, again, to evaluate the comparative effectiveness and maybe point like future directions for research in this field.
That's amazing research, actually. I find it's just again the fact that it covers so much ground and it promises a lot of changes and a lot of good changes.
Yeah.
So I think it's amazing that you're doing this research. You and your team, we do need people like you doing this type of work. It's work that people don't often realize that is being done.
Yeah.
But
or not even realize that it's necessary. Because like especially opioids are taken for granted so much. Opioids are the painkiller. It's the only thing that kills pain. But the reality is that like research does not support that. And like we just like as following our scoping review, one of the things that we realized is that there are not many meta-analyses, which are like literature reviews that like focus on comparative effectiveness of like opioid versus opioid analgesics. And we're just about to submit a paper like reporting a big meta-analysis on this field that really shows that like opioids are not superior to non-opioid drugs when treating post-operative pain. And
that's
yeah,
amazing.
we are like super excited about it.
When humans have a practice, I feel we're very conservative about these practices. And the medical field is not immune to that. And so it's good that you're pushing this research forward so that we can know what practices are best and which one we can adopt in the medicine of tomorrow. So thank you so much, Dr. Julio, for coming to the podcast.
No worries, my pleasure. Thanks so much for the invite once again. It was great.
Thank you for the conversation.
Thanks, guys.
Thank you for listening to Orders of Magnitude. If you enjoyed this episode, please leave us a 5-star rating on Apple Podcast and share the episode with your friends and family. If you would like to give us feedback, you can reach us at ordersofmagnitudepod@gmail.com. We would love to hear your opinions and ideas on the subject that we discussed today. Orders of Magnitude is an original project led by Philippe, Carle, and Matheus Schultz. The original music was composed by Vincent Ellis. Stay tuned for the next episode coming out in 2 weeks.